online anesthesia video of this week. You can also participate in this program if you are interested. Just record your video presentation on Zoom platform and send to us in onlineanesthesia@gmail.com. For further rules and regulations, please visit our FB page online anesthesia. Let us watch this week's video.
Dr. DEEPAK PRAKASH BORDE, Consultant Cardiac Anesthesiologist, Ozone Anesthesia Group, Aurangabad, Maharashtra. He did fellowship in cardiac anesthesia from Jadava Institute, Bangalore, and fellowship in transesophageal echo from Indian in 2015 and European Board in 2016. He had cleared advanced PTA exam by National Board of Echocardiography, USA 2019. He has won prestigious Janak Mehta Best Paper Award in National Conference 3 times: IACTA Kochi 2013, IACTA Mumbai 2014 and IACTA Chennai 2016. On editorial board of Annals of Cardiac Anesthesia and IACTA Echo Library, guest reviewer of JCVA. He has published 25 original articles in Journal of Cardiothoracic and Vascular Anesthesia, Annals of Cardiac Anesthesia and Indian Journal of Anesthesia. He has conducted 2 national level surveys on practice pattern of TEA and CPB in India.
Hello everyone. Today we will be discussing on FATE, that is Focused Assessed Transthoracic Echo in Perioperative Period for Anesthesiologist. I'm Dr. DEEPAK BORDE. I'm a Consultant Cardiac Anesthesiologist in Ozone Anesthesia Group, Aurangabad, Maharashtra. So why anesthetists should learn echocardiography in first place? There are multiple reasons for this. First and foremost, the complexity of the cases that every anesthesiologist is facing nowadays is increasing day by day. So hardly you get a patient who has got no comorbidities. And every time the help of cardiologist may not be available in the remote places. It can be odd hour surgery where cardiology help is not readily available, or some of the nursing home practices where the cardiologist is on call. So you cannot wait. This can delay the surgery significantly. At the same time, every anesthetist nowadays is being exposed to ultrasound guided nerve blocks and various procedures, including central line insertion and other procedures. So we all know about the ultrasound knobology. We all know how to obtain images, and we all know how to optimize the images. So with this, all these basic skill set of ultrasound in our background, doing an echocardiography is just one step away from our important goal of hemodynamic assessment and hemodynamic optimization of our patients. So I'm very happy to share that American Society of Regional Anesthesia, they have published our manuscript and our images on advanced focus assessed transthoracic echocardiography last year. And I would encourage all the viewers to go through this document. There are other important documents on basic FATE also, which are available. So in next 20 to 25 minutes, how we will discuss. We will see for the 6 real life case scenarios which I have encountered. Out of it, 5 are FATE cases and 1 is a lung ultrasound case, because lung ultrasound is essentially part of echocardiography assessment. So we will see what are the basic views of echocardiography, what all the 5 important numbers or 5 important calculations that we do based on echocardiography. So these include CVP or a preload assessment, LV function, which we all are very, very important and we all should know about it. The RV function, right ventricular function, the PA pressure assessment, and the cardiac output assessment. So once we see how we get all these numbers and calculations, we will try to solve these 6 cases based on echocardiography. So just remember these cases, no need to go into detail. Case number 1 is a young guy who is undergoing an emergency laparotomy for blunt trauma abdomen. Splenectomy is performed for ruptured spleen. During surgery, you think you have given adequate fluid, including colloid. Post closure, the blood pressure is still in the range of 70s and 80s. So you start noradrenaline, but BP just becomes 80 systolic. In the worry, you send one ABG, which shows good PO2. and reasonably okay hemoglobin of 10.5. Will you extubate this patient, or you need something else or more concrete data to make your decision? Case number 2 is another young guy who is referred to your hospital for fracture femur for road traffic accident 3 days back. Patient is a chronic smoker. On the preoperative evaluation, anesthesiologist notices that saturation is 85% despite O2 on nasal prongs. The chest X-ray, although, is unremarkable, and you do not hear any major adventitious lung sounds, or the chest is not that bad on auscultation. So your orthopedician is insisting that you should induce this case because this guy is a chronic smoker. He is bound to have low saturation. So would you induce this patient, or you need some more information? Case number 3 is a 24-year-old female who presents in 3rd stage of labor in middle of night. There is significant history of balloon mitral valvotomy done 4 years ago. Since that, patient has not followed up with the cardiologist. On auscultation, you hear a mid-diastolic murmur. There is a fetal distress, and obstetrician wants to proceed with LSCS at earliest. But cardiology help will be available only in the morning. So before this shifting this patient to OT, would you like to perform any focus assess transthoracic echo assessment? Case number 4 is an elderly male who has long-standing history of hypertension and diabetes. He has undergone total knee replacement 2 days back. His preoperative evaluation was completely normal. So you are just about to shift this patient from ICU. But on monitor, the nurse and the resident doctor notices a ST depression. So there is no chest pain. How will you proceed with this case? Case number 5 is a young lady who is posted for dilatation and evacuation for missed abortion. She has very good exercise tolerance, but history of occasional palpitations. On auscultation, you hear a systolic murmur, and you order an ECG which shows right bundle branch block. So what next? Last patient is a 52-year-old female. She's posted for kidney transplant. Patient has undergone hemodialysis a day prior. All hematological parameters are optimized, well optimized by the nephrologist. But on auscultation, there is reduced air entry on right basis of lung. Patient is maintaining saturation of 98% on room air. What you will do next? Okay, so just keep these cases at back of your mind, and we'll try to solve them one by one. Okay, so coming to echocardiography proper. So there are 3 important echo windows which are commonly done and commonly assessed. First and foremost is a subcostal window. Second is apical window, and third is parasternal window. So in this figure, you can see the respective position of the probes in relation to the heart. From subcostal window, you are looking from a subcostal angle towards the heart. From the apical window, you are looking from the apex of the heart, and parasternal window is just lateral to the sternum in second or third intercostal space. So these are 3 important windows that one should know. At the same time, there are 3 important probe maneuvers that you should be aware before you start your journey of echocardiography. First maneuver is a tilting maneuver. So tilting maneuver is doing a tail from tail up to tail down, or tail down to tail up. So what this maneuver does is it can interrogate the heart from anterior to the posterior and vice versa. So posteriormost structure of the heart is coronary sinus. So on the left side of the figure, if you can see, from the posteriormost structure of coronary sinus to the anteriormost structure, that is pulmonary artery. So all this can be seen by doing tilting maneuver and keeping the probe at the same place. The second important probe maneuver is the rotation. Rotation is the movement which allows you to assess the heart from any window from long axis to the short axis. So it can convert your long axis image into a short axis image. And third important maneuver is the sliding scanning maneuver, which means you are scanning from one intercostal space to another. You are actually sliding the probe from above to below or below to above. Excuse me. Yeah. So the first window that we saw is the subcostal window. So before you start scanning, it is very, very important that you choose a phased array probe. Okay, there is a marker which is peculiar to every manufacturer, and you should know the where your orientation marker is. So at times it can be a green glow, at times it can be a notch which is there on the phased array probe, depending on the manufacturer. So you should pick up that probe and you should know the orientation marker. Second important thing is how the patient is positioned. For obtaining a subcostal view, the patient usually lies supine, and you put in the probe in the subcostal place. So just below the xiphisternum, you keep the probe facing the orientation marker towards the left shoulder of the patient. Okay, and the moment you put it, this grip, which you can see, is called as a screwdriver grip. So as if you are holding a screwdriver. And in this particular subcostal view, you have to be as parallel to the skin as possible. So if you are holding probe from the top, as if you are holding the screwdriver, you can be parallel to the skin of the patient. So what you see on the echocardiographic image is, on the top you see liver, just below the liver is related right ventricle, below that is the right atrium, then you see interatrial septum, then you see the left atrium just adjacent to it. Below the left atrium, you can see a descending thoracic aorta. So left atrium being a posterior structure of the heart, it is related to the descending thoracic aorta, which is lying posterior to the heart. So that is how you identify which is left atrium and which is right atrium. The one which is in relation to the liver is the right ventricle, and the other ventricle will be the left ventricle. This view is very, very important view because it is easy to obtain, first thing. Second thing, in patients who are difficult to image, like somebody who is very obese, somebody who has got COPD, or at times if the windows are not good, very hairy chest, in that case this view comes as very handy. In this view you can see all the four chambers of the heart, you can see the interatrial and interventricular septum of the heart. This view is excellent view to diagnose pericardial effusion. Another point which I told is you can identify the descending thoracic aorta. So that structure is an important landmark, because if you have got an effusion which is above the descending thoracic aorta, it is usually the pericardial effusion, and below the descending thoracic aorta, it is usually the pleural effusion. From the same subcostal four-chamber view, if you rotate the probe anti-clockwise, okay, so in this way, the orientation marker now faces cranially. Okay, and from this important structure that you get is the IVC. So inferior vena cava is very clearly seen. Okay, so this is an inferior vena cava in the long axis view. So how you can determine a CVP or central venous pressure based on echocardiography? First, you obtain the subcostal IVC view. Then you put an M-mode cursor 1 centimeter from the IVC RA junction, that is the right atrium junction. And if the IVC diameter is less than 21 millimeter and the respiratory collapse is more than 50%, we say that IVC is empty and collapsing. That goes to say the CVP is around 5 or less. On the contrary, if the IVC diameter is more than 21 mm and there is no respiratory collapse or there is no respiratory variation, we say that IVC is dilated and full. And in that case, CVP is usually more than 50. As you can see on the left side of the image, the diameter is 18 mm on inspiration and 6 mm on expiration, and you can very clearly visibly see that it is collapsing well. So CVP in this case will be less than 5, and on the right side of the image, the largest diameter is 28 and the smallest diameter is 18. So this is not collapsing. So in this patient, the CVP will be more than 15. Coming to the second important window, that is apical 4-chamber view. So in this case, as you can see, the patient is given a left lateral position. It is very important to note this position. The patient is given, patient's left hand is working like a pillow, right hand is lying straight. So in this case, the orientation marker is facing towards the left shoulder of the patient, and the four structures, four chambers of the heart are clearly seen: the right ventricle, right atrium, left ventricle and the left atrium, and tricuspid and mitral valve. So it is important to know that the tricuspid valve is placed more apically. That is how you identify the ventricle as the right ventricle. So in this image loop, you can very clearly see this is a good 4-chamber view. Why I am saying it is a good apical 4-chamber view? Because your interventricular septum and interatrial septum are right vertical. So that is an important point. So when you are doing any measurements, it is important to, sir, can you please mute? Can you please mute that? Thank you. So the interventricle and interatrial septum should be vertically placed. Okay, but at times, if you are seeing a structure which is very much anterior, that structure is LVOT and aortic valve. So in that case, you have to do a tail up maneuver. So you need to, so you are seeing the LVOT, that is an anterior structure of the heart. So you have to take out that structure. So you have to do a tail up maneuver. So you need to see more posteriorly. But at times, if you are not seeing the atria at all, that means you are interrogating too much posteriorly. In that case, a little bit of tail down and you will get a good apical 4-chamber view. Many times it happens that when you keep the probe on patient's chest to get a 4-chamber view, the interventricular septum is obliquely placed. So in this case, you have to move the probe laterally to get a good apical 4-chamber view. Apical 4-chamber view is very important because it gives an idea about all the 4 chambers of the heart, and that is what is the basic image. So when you are talking with the patient, we are giving information from one clinician to other, this is a very important view. So then comes the next view of parasternal long axis view. In this view, again, patient is lying in the left lateral position. Now your probe is placed on the second or third intercostal space. This is an important reminder that the orientation marker in this view is facing towards the right shoulder of the patient. And what you see on the top is the right ventricular outflow tract, RVOT, interventricular septum, the left ventricle, the mitral valve, the left atrium, and on just below the RVOT will be LVOT, aortic valve, and aorta. So this is on the top, this is right ventricle, RVOT actually, then interventricular septum, LV, mitral valve there, left atrium, aortic valve, and aorta. So if you rotate the probe, so remember the 3 important maneuvers that we talked. So if you rotate, just keep the probe in the same place, but rather the orientation marker, rather than facing the right shoulder, now faces the left shoulder. So what you get is the parasternal short axis view. So image is converted from a long axis to short axis, and this view is very, very important because it gives idea about coronary supply of all the 3 coronary arteries. So what you see in the middle are the 2 papillary muscles, and what we see on the top is anterior and anteroseptal area, which is supplied by the left anterior descending artery or LAD artery. On the lateral side is the anterolateral and inferolateral segments. This area is usually supplied by the left circumflex artery, and the inferoseptal and inferior area, which is supplied by the right coronary artery. So it cuts across the heart as if it is a donut. So as you can see here, these are the 2 papillary muscles, RV, interventricular septum, and the 6 segments of the heart. So how do we assess the left ventricular systolic function? So commonest method in the FATE is eyeballing. So you have to train your eye and train your mind. That you can do by looking at multiple images of the patient. So a good left ventricle is contract synchronously during the systole. There is good inward movement, so there is no regional wall motion or difference in the movement of the segments of the left ventricle. Compare that with the right-sided image, where you can very clearly see the heart is struggling, and during systole there is hardly any inward movement. So this image you have to keep it in your mind, and you should know whenever you are doing a parasternal short axis assessment. Then comes an important measurement, that is ejection fraction. Usually it is done by an M mode. In the parasternal long axis view, you cut across the heart in the mid segment, and you measure the internal diameter in diastole and internal diameter in systole. So this is internal diameter in diastole and internal diameter in systole, and what you get is the fractional shortening by this formula of LVIDD minus LVIDS divided by LVID during diastole. So the normal value is 26 to 45%, and ejection fraction is 2 times the fractional shortening. So in this case, the fractional shortening is 33% and ejection fraction is 64%. Another simple M mode measurement that you should know is the MAPC, or mitral annular plane systolic excursion. So this measurement is obtained in apical 4-chamber view. The M mode is placed on the lateral aspect of mitral annulus, and a value more than 12 mm is indicative of normal LV systolic function. Another important measurement, very simple to obtain, is EPSS, or E point septal separation. So this is obtained from a plaques view, again through M mode. So we usually cut across, put an M mode or cut across at the mitral leaflets, and you can see the trace of anterior mitral leaflet here, and the distance from this movement of anterior mitral leaflet to the interventricular septum. So this distance is measured, and that distance is called as EPSS, or E point septal separation. And if the distance is more than 7, that indicates LV dysfunction. So if the heart function is normal, so this mitral valve will come very close to the IVS. So the smaller distance indicates a normal LV function, a larger distance indicates LV dysfunction. So we have published this paper on utility of this E point septal separation as a screening tool for LVEF in perioperative setting by anesthetist. So another important method is a volume method, which is called as Simpson's method of discs. Here the in apical 4-chamber view, the end diastolic and end systolic volumes are traced. There are softwares available in the machines, and a normal value indicates more than 55%. So according to American Society of Echocardiography, this is the gold standard measurement. So coming to the RV systolic function. So again, RV systolic function is assessed by eyeballing, and a dilated RV, usually the right ventricular size is around half that of the left ventricle. So if it approaches of the same size of the left ventricle, the RV is already dilated. And in this case, you can see the right ventricle is bigger than LV. So this is massively dilated right ventricle. And another important criteria is the right ventricle forming the apex of the heart. So these are important criteria for right ventricular systolic assessment. So if you have to do a quantitative assessment, that is done by TAPSE. This is similar to the MAPC, but here you keep the M mode cursor on the tricuspid annulus, and you look at the tracing, and the tracing is from the top of this curve to the bottom, and a value more than 16 mm is indicative of normal RV systolic function. In case of MAPC, it is 12, but in case of TAPSE, it is 16 mm. Important parameter of PA pressure, because severe pulmonary hypertension is an adverse indicator of adverse outcome even in the minor surgeries. So tricuspid regurgitation is used for measuring the PA systolic pressure. So how do you do that? You put an color flow and you see for the regurgitation. So regurgitation is flow coming towards the right atrium. So on the right side of your screen, you can see the severe TR. So from that color flow or wherever there is regurgitation, you put an continuous wave Doppler cursor. Okay. And in this case, on the right side of the image, the TR maximum velocity is 4.75, giving the PA systolic pressure of around 100 millimeters of mercury. So any value, you can just remember, any value of TR maximum velocity more than 4 meters per second describes it as a severe pulmonary hypertension. So in case of hemodynamic instability in normal bioventricular function, where you can see it as in case of massive pleural effusion as seen in this case. So another important measurement echocardiographically that we can do is the cardiac output. It is done by measuring the stroke volume and multiplying it by heart rate. How do you calculate stroke volume? By LVOT area and LVOT length. How do you actually calculate the LVOT area? Is by measuring the radius of the LVOT. And how do you calculate length? Is by measuring the VTI of LVOT. Okay, so the radius of LVOT is measured in the parasternal long axis view, and VTI is measured in apical 5 chamber. Okay, so you can see it here. The LVOT VTI is 21.8 centimeter, which is measured in 5 chamber view with the help of a pulse wave Doppler. And the LVOT diameter in this case is 24 mm, and heart rate is around 90. So it gives rise to a cardiac output of 8.77. Because we have entered the body surface area, it gives rise to the cardiac index. So now we'll see shortly in this video, which we have put it in ASRA website. So measurement of cardiac output with echocardiography, obtain a plaques view, freeze it in mid systole, measure the LVOT diameter 1 centimeter from aortic valve during systole. So in this case, it is 2 centimeter. Put a color flow across apical 5 chamber view, then put an pulse wave Doppler at LVOT to measure the LVOT velocity time integral, that is VTI. So cardiac output is nothing but stroke volume into heart rate, and that can be measured here as shown in this calculation. Alternatively, you can measure the stroke volume with Simpson's biplane method, wherein you get directly the stroke volume and you multiply it with heart. So far we know how to assess the RA pressure or the CVP by using a subcostal IVC view using M mode. Eyeballing and some basic quantifications like MAPSE, ejection fraction for the LV systolic function. RV systolic function is again by eyeballing, and PA systolic pressure measurement is by apical 4 chamber view and TR velocity. So TR velocity more than 4 meters per second indicates severe pulmonary hypertension. So cardiac output is measured in 2 views. For plaques view, you measure LVOT diameter, and apical 5 chamber or apical long axis view for LVOT VTI. So now coming to our cases where we left in. So this young guy who has undergone laparotomy for ruptured spleen, you think you have given adequate fluid, but look at this parasternal short axis view. So this sign is classic sign of kissing ventricles. So kissing papillary muscles. So as if the two papillary muscles are kissing each other. So this is a sign of severe hypovolemia, and on the top of it you are seeing a very small narrow IVC which is highly collapsing. So what is the diagnosis? Still the patient is having hypovolemia, and still the patient needs more volume. So you empirically think in your mind that you have given adequate fluid, but the figures don't lie. Okay, so figure is clearly this is a underfilled ventricle and you need to give more fluid. Coming into the second patient who is a fracture femur patient, a smoker. So your orthopedician is behind you. Please start this case. But you say, wait, I will put an echocardiography probe on this patient and look what you see. You see a dilated right ventricle. Why dilated? Because it is bigger than the left ventricle. Okay, and then you quantify the right ventricular function by measuring this TAPSE. Remember that we have said that a value more than 16 mm indicates a normal RV systolic function. In this case, it is only 11 millimeter. So there is definite reduction in the right ventricular systolic function and right ventricle is dilated. So looking at the history of the patient of fracture femur 3 days back, your diagnosis is suspect a pulmonary embolism. Do not induce this case unless you have done basic workup for pulmonary embolism like a CT angiography. Then only post this patient. Otherwise, a sure shot mortality is waiting for you. Okay, coming to a third patient who was in the third stage of the labor. After the balloon mitral valvotomy, there was no follow-up. Cardiology help is not available, but you can do echocardiography. Just put in the probe and you can see that there is massively dilated left atrium. And you can see here a sluggish flow of the blood in the left atrium. So this left atrial flow is called a spontaneous echo contrast. You can see a mitral valve is calcified. Mitral valve is not opening well. And you can see a interatrial septum is bowed towards the right side. That means there is massive increase in the left atrial pressure. You obtain the IVC view and you document that IVC is dilated 33 mm and not collapsing at all. You measure a PA systolic pressure, which comes out the PA maximum velocity is 4.18. So PA pressure is 85 millimeters of mercury. So what is your diagnosis? This is a severe mitral restenosis, because although the patient has undergone BMV, still there is component of mitral stenosis with severe pulmonary hypertension. So here you have to remember that you are not here to postpone this case. You will still induce this patient, but there is a lot of information available to you, and with this information you can do a shared consent. You can take high risk consent. You can tell the patient that she may need a post-operative ICU, she may need a post-operative cardiology care. So you take much more informed decision in this patient. So you are well informed. You can inform your obstetrician that this is a high risk case, and if suppose there's not much of help available, you can shift this patient to a higher center where adequate help is available. So coming into the fourth patient who has undergone TKR 2 days back, and you notice a ST depression on ECG. Then you calculate the ejection fraction. Look at that. Ejection fraction is still 56%. There's no change in the ejection fraction. But in the parasternal short axis view, you notice that the anterior and anteroseptal segments are not actually moving very well. The lateral segment, the inferior segment is moving very well, but this anterior anteroseptal segment is not moving well. So in this case, you send a TROP-T, you document that there is new regional wall motion abnormality which has happened after the operation. So this is a classic case of post-operative myocardial infarction that you have made. And this is very, very important to diagnose. If you are in charge in the intensive care unit, this is a very important diagnosis. Coming to a fifth case, young girl who is for missed abortion, posted for D&C. You notice a right bundle branch block, and just put in the probe and the diagnosis is staring at you. Look at that. What is this? The interatrial septum, there's a big, huge defect. Okay, so you hear a systolic murmur, you see a right bundle branch block, always suspect a ASD. So in this patient, the diagnosis is large ASD. Okay, the sixth case is 52-year-old patient who is posted for kidney transplant. All the parameters are well optimized. Nephrologist has done everything possible, but there is reduced air entry on the right basis. So a fate examination is not complete without looking at the lungs. So you just put in the probe in the right base of the lung and look what you see. A very massive pleural effusion. So there is collapse of the underlying lung. So this need to be addressed at the time of surgery or just before the surgery to have very good outcome after the surgery. So what do all these cases or case scenarios tell you? That only thing that you need to do is develop a systematic approach. You can do echocardiography by yourself. So all these images which I have shown, all the images are acquired by either me or one of our anesthesia colleagues. So I would like to thank all of them, because all the things got diagnosed in the nick of time and you can give better to the patient. So you are more vigilant, you can do better for your patients if you know the echocardiography skill. And those who are already doing ultrasound guided blocks, it is just an extension of your skill set. You just need to upgrade yourself with the orientation, because many of the echocardiographers nowadays, at least in corporate hospitals, are the technicians. So they know how to obtain the images. Please spend some time with them. They will give you definitely good tips and tricks on how to optimize the images. If you do, just get those 3 or 4 basic views first. If you can develop that skill set, definitely I'm 100% sure that you can help your patients a lot. And particularly when you are all alone, when there is no cardiology help available, but there is a machine standing there. So all you need to do is just pick up the probe, put it on patient's chest at right position, know what you are about to see from that view, and you can make a difference. So nowadays, artificial intelligence is coming up and there are newer portable machines. So this is a new machine which has got just a probe and a small tablet. That's all it has got. So it can tell you, you optimize the image by pressing it harder, by doing fanning out. It can show you the image is good or bad. Bad image is represented as red, good image as green. So you know how to optimize the image. So all this is by artificial intelligence. It is coming in a very big way. So machines are going to do all the measurements for you. Just wait here and see what the machine has calculated. Machine has calculated ejection fraction, stroke volume, cardiac output, everything. Just less than a minute, it can give you all the necessary information. Thank you very much for your patient listening.